welcome back. Last time we left off after finishing half of block 2, so I'm going to continue on with the rest of block 2 right now. Again, I have been doing the explanations the same day I'm kind of coming on live to talk about them. So today I got up to, I believe, 110. I've seen a lot of neuro questions. I've seen a lot of, got this little list over here where I'm trying to list out all the topics that are being discussed. So it helps me kind of see what topics NBME is kind of picking on. It's nice to be able to evaluate what's happening in that aspect. I got up to, where am I right now? Yeah, 110. So the last two questions just happen to be two public health science questions about normal aging and primary health prevention, something like that, back to back. I'm pretty sure those are going to be the only public health science questions and whatnot. But yeah, I've been seeing mixed stuff as NBME tends to be. So organizing a list like this for every single NBME you review is pretty handy because you get to have a good understanding of things that you need to revise, right? So like if you were done with this NBME, you would look at this and be like, okay, renal creatinine clearance, what do I remember? And you would try to come up with the explanation for creatinine clearance with respect to inulin and whatnot from your head, right? Micro onchocercal volvulus and everything else that has been seen in this test. You would also revise in your head what that specific question was about. How did that question look like? Stuff like that. So that kind of active revision is always extremely helpful. It's nice to do. It really, it sets the picture together for you, so you can go ahead and figure out what's happening. Now, continuing on, this is where we were up to. So question number 26. Keep in mind, as usual, the first page number here is the page number for First Aid 2019. The second number written here is the page number for my annotated first aid, which I do sell. So if you're interested in buying it, you can always feel free to reach out to me through my email address. It should be in the description below. So questions like this almost always piss people off because the picture given of what might be a gross brain is always really difficult to actually pick arteries from compared to like a really nice diagram, right? So 71-year-old man is brought to the emergency department because of the sudden onset of dysarthria, dysphagia, and dizziness. Examination shows markedly decreased pain sensation on the right side of the face and complete loss of pain sensation on the left side of the body. The most likely cause is occlusion of which of the following labeled blood vessels in the normal brainstem shown. So the giveaway in this question stem is the dysphagia, and you're always supposed to remember the neurological mnemonic of don't pick a horse that cannot swallow, and that's supposed to remind you of pica infarction. Right, so that's a posterior inferior cerebellar artery, and the only posterior thing they're pointing at here that's cerebellar is D. So they made this really easy in that aspect. It wasn't even a matter of left or right. It's just the fact that it's back there, and that's the only thing they're pointing at back there. Had they had another answer choice, where maybe they pointed at this one here, and this was answer choice F, then that would make things a little more difficult, right? So at that point, you would have to figure out what's ipsilateral, what's contralateral, and stuff like that. Well, they tell you that the patient has decreased pain sensation on the right side of the face, right, and complete loss of pain sensation on the left side of the body. So decussation always occurs when you go into the body, so it's going to be the same side as the face, right? So right side. So this is the right side for the patient's brain, the way the patient is looking at you, and that would be answer choice D, basically. So nothing intensely insane here. Lately I've been seeing a lot of comments on my neuro videos, people telling me that they really found it to become a lot easier, mainly because of the time I invested into making those videos, right? So for these effects of strokes, I did a really good job putting together good pictures and good notes for exactly what happens in each one of these. You want to make sure you understand the nuclei that are involved, the area of infarction that's involved, and what that causes, right? Because oftentimes you can even get diagrams like these guys, and they could be labeled with answer choices. You want to make sure you're ready with that. Our patient was about pica. You want to, know all the different nuclei, all the different consequences of those nuclei, and then of course earlier from the anatomy section, you have your the anatomy and physiology section, you have all your different tracts. You want to be able to reiterate these tracts from your mind, right? You shouldn't need the book to be able to talk about these tracts. You should know exactly how they travel and what they use on their way down and up. This NBME, I've gone up to question number 110, and there was a second question about pica. Different presentation, different way to ask about it, but same exact disease. They had a second question on it, so we'll see that when we get there. Here, this is a 40-year-old man with AIDS develops severe diarrhea that is refractory to all standard oral therapies. His diarrhea resolves after IV administration of a stable analog of a naturally occurring hormone. The analog administered most likely mimics which of the following hormones, right? So they made it very clear what they were trying to get at if you have studied this before. But in general, the guy has diarrhea and you want to stabilize everything, so the best thing to give is somatostabilizer, right? Somatostatin. Somatostatin has an analog, which is what they're asking about, and that's octreotide. If you look at all the other medications, you probably can't think of an analog that can be used as a medication for those different hormones, but somatostatin does have an analog, and that's octreotide, which would help with this diarrhea. The other hormones do not have a commonly tested analog as a medication, and that's all this question was really about. 28 was interesting, good way to ask about this. So 25-year-old woman at 16 weeks gestation comes to the physician for a routine examination. 1 year ago, she had a serum thyroxine T4 concentration of 8.2 and a serum TSH of 2.1, which is within the normal range. TSH has a pretty varying range depending on your gender and whether or not you actually take levothyroxine or you're perfectly fine. At that time, which is before she was pregnant, she was not taking any medications and she was not pregnant. At this visit, serum T4 concentration is 13.2, so it's higher. Serum T4 concentration is higher, and serum TSH concentration is about the same still, which would be her normal still. Which of the following is most likely responsible for the increased serum T4 concentration in this patient? So you have to understand with questions like this, where they talk about T4 and T3 concentration, you have to think of what they're talking about. Are they talking about free T4, bound T4, T4 that's actually active, right? Only free stuff is active. Bound things are not active at all. So that really helps. And then, of course, the big giveaway in this question was the fact that she's pregnant. And you need to know all the things that change during pregnancy. So this patient doesn't have hypo or hyperthyroidism or anything. Her T4, total T4, is going up because chances are a lot of her T4 is being bound by thyroid binding globulin, so she keeps making more. Right, so free T4 would actually be about the same or lower than it was when she was actually pregnant, and now her total T4 is higher because she's making more T4 to basically create free T4. And that's relevant to pregnancy, oral contraceptive use, hepatic failure, steroid use, or nephrotic syndrome. The hepatic failure, steroid use, and nephrotic syndrome are cases where you lose protein. So you would lose your thyroid binding globulin and you would have more T4 that's free. And in those cases, patients can present with hyperthyroid symptoms. Here, this patient could eventually present with hypothyroid symptoms. Right, so pregnancy and thyroid are a big deal, also because of similarities that other hormones can often carry to TSH. And that's another thing that often gets tested, right? Other hormones that are very similar to TSH, which basically comes from beta-HCG. The alpha part of HCG is very similar to many hormones, and it can mimic thyroid hormone and cause pregnancy-induced thyroid problems. So that's all this was about. Nothing insane. This is actually discussed in the book too, 361. So let's take the book. Right here, right, they talk about it at the bottom. Thyroxine binding globulin, very high yield topic. They love bringing it up. NBME especially loves bringing it up. So you have to remember TBG is increased in pregnancy and oral contraceptive use, or and it causes you to have more total T3 or T4 because all of it is bound, so you keep making more. It's a negative feedback. And the opposite would be true for hepatic failure, steroid use, and nephrotic syndrome, where you lose protein. This is also a recurring theme question that almost every NBME has asked, and I also put a UWorld question of the same topic here with the image I found online to show you something. So this 3-month-old girl is brought to the emergency department by her parents because of a 2-day history of deep cough that sounds like a barking seal. a runny nose, and decreased appetite. Temperature is high. Physical exam shows inflammatory stridor. Diagnosis of croup is made, but the appropriate treatment does not result in improvement. Examination of the airway after anesthesia is administered shows two squamous warty lesions on the vocal cords. Which of the following viruses is most likely responsible for those lesions? These are also often called papillomas, finger-like projections, etc., etc. You can see that is in the UWorld question explanation. They call them papillomas on the true vocal cords. You have to remember that part. You also have to remember from the same explanation that it has a tendency to go for stratified squamous epithelium. Alright, so this is all HPV, which is answer choice D. The warty lesions on the true vocal cords are a result of the lower number HPVs 1, 2, 6, and 11. Alright, so very high yield NBME topic, very easy overall medical topic, so definitely, shouldn't have a problem looking at this. What they did try to get you with, and I'm surprised they, I'm sure a lot of people fell for it actually. So let's go back and look at what they were trying to get at with the croup. So let's see. These are just embossed images for each of the rashes, pediatric rashes. Let me find the croup thing. Right here, right? So your paramyxoviruses, right? Paramyxoviridae, is it? Acute, it's right up here. Acute laryngotracheal bronchitis. This is basically croup, the longer name for it, right? Caused by parainfluenza virus. And I'm surprised that they didn't put it as, an answer choice. They put poxviridae, but they didn't put the parainfluenza or paramyxoviridae as an answer choice, because that's what they were leading you to: the seal-like barking cough, the respiratory stridor, the croup, and whatnot. Instead, they made the question easier by telling you that the croup treatment didn't work, which means that it's not croup. So if I was the question writer, I would definitely not have said that, and instead told there was no improvement. We're not sure what's wrong. Physical exam shows this. What might have happened? But either way, not a bad question at all. Number 30 here. 80-year-old woman comes to the physician because of a 1-month history of intermittent headaches and aching pain in her jaw while chewing. She has no history of similar headaches or pain. Neurologic exam shows no focal findings. Which of the following is the most appropriate next step in establishing the diagnosis? So this is a very real presentation, right? Your patient can come in, 80-year-old. She just tells you she has headaches and pain while chewing, nothing else. So what do you order? Well, the first thing you would do is understand that this pain with chewing in the jaw, this is called jaw claudication. It should ring a bell for temporal arthritis, and you would immediately prescribe her prednisone so she could start taking that. And the dosage of prednisone is always based off of varying things, but you have to remember that it has to be taken with incremental dosing and then tapered off with a decreasing dosing, right? So that's what you have to prescribe. And you do it because temporal arthritis can lead to ophthalmic artery occlusion, leading to irreversible blindness. So you don't wait for the diagnosis to be confirmed to start the prednisone. You just prescribe the prednisone ASAP, get that going, and that's all it's going to be. That prednisone alone will actually end up helping her with her pain, with everything, and she should be better off. So that's all that was wrong in this patient, right? Headaches and jaw claudication. And that jaw claudication was what would remind you to order a ESR, right? Because this is an inflammatory process, so erythrocyte sedimentation rate would be higher than normal. And that would be true for almost all of these vascularities, right? They even tell you here, elevated ESR, elevated ESR. Almost all of these guys would have elevated ESR because there's some level of inflammation going on in all of them. So it's just a repeating fact. And another presentation of that same topic is often co-introduced with polymyalgia rheumatica, right? Because it is associated. So you can have a slightly younger woman, maybe someone that's 40 or 50, coming in telling you she has all this body pain everywhere. That's the polymyalgia rheumatica. She might also mention she's been getting headaches, a little bit of pain with chewing or something, or she has temporal headaches all the time, something weird like that. And you have to be able to figure out the fact that there is a association with polymyalgia rheumatica, PMR, and temporal arthritis, and you give them the corticosteroid. Thankfully, the corticosteroid would be necessary for the polymyalgia rheumatica too, so it would work out for both of them. And you don't have to give anything separate for temporal arteritis, but you would still need to do what you need to do to come to a diagnosis so it can be established. Next question here, 31. A 50-year-old man comes to the physician because of diarrhea and a 30-pound weight loss over the past 2 months. Crazy. He has 3 to 4 large, pale, foul-smelling stools with oil droplets daily. So it's not bloody diarrhea, it's malabsorptive diarrhea is what I like to call it. This is malabsorptive diarrhea because it's basically just full of fat, right? So it's fatty diarrhea. He has a history of alcohol dependence and chronic abdominal pain. X-ray of the abdomen shows calcifications in the mid-upper abdomen. Which of the following pathophysiologic mechanisms is the most likely cause of the condition? And it must be generalized malabsorption. Most likely, his alcohol dependence has caused him to get chronic pancreatitis. And pancreatitis is what's causing the calcification. It's becoming calcified. That's the pancreas that they're seeing on X-ray. And without pancreatic enzymes, you would have a really hard time absorbing everything. The other answer choices are completely irrelevant. This was a cool question, totally an NBME style question. So 58-year-old man is brought to the ED 1 hour after being kicked in the side by a horse. 2 years ago, he was diagnosed with chronic idiopathic myelofibrosis. He drinks 2 12-ounce beers daily. Temperature is fine, pulse is 120, respiration is 18, blood pressure is low. Abdominal exam shows guarding and tenderness over the left upper quadrant. So, you know, when they mention quadrants like this, you always want to think of what's there. Right upper quadrant, you think of the gallbladder. Left upper quadrant, you think of the spleen. Right lower quadrant, you know, you start thinking of other things there, and left lower quadrant is another set of things based off of the intestinal things, the appendix, the various valves, ileocecal valves, stuff like that. For our guy, they mentioned the left upper quadrant, so you immediately think maybe something happened to the spleen. Lab studies show anemia, right, but the leukocyte count and the platelet count is perfectly fine. Ultrasonography on the abdomen shows intraperitoneal fluid. 4 hours later, his hematocrit is 24%, so it's decreasing from 27. Laparotomy is most likely to show what? So, there were multiple things giving away the fact that it is the spleen, besides just the fact that they mentioned the left upper quadrant. There's also the idiopathic myelofibrosis this guy has. So myelofibrosis is fibrosis of your bone marrow, and you would see dacrocytes, right? That's something special about myelofibrosis. And you also get splenomegaly. So this guy would have a slightly bigger spleen than most normal individuals. On top of that, being kicked by a horse is no joke. That's pretty much like getting into a car accident. So all in all, being kicked by a horse is trauma, which is notorious for causing splenic rupture, right? So this guy most likely had a ruptured spleen. Why did I put D? Excuse me. And that would be the answer, and you would just move on. You know, nothing else is crazy about it, because the other answer choices do not make any sense for this patient. It would not be a mesenteric artery thrombosis. Thrombosis of one of those mesenteric arteries would present with blood in a different area. Remember, they mentioned this is intraperitoneal. You always want to think of all the things that are retroperitoneal when they mention things like this. And it's intraperitoneal, so the mesenteric artery thrombosis would not make sense. Pancreatic pseudocyst is irrelevant here. That would be also a different set of issues, right? You're not going to get a pancreatic pseudocyst because you were kicked by a horse. That's not how that works. A kick by a horse can lead to a perforated stomach, although that's pretty unlikely. The stomach is a very strong, rubbery composure, so it would get perforated if it already was weak to begin with, maybe because of gastric ulceration or something. And a ruptured bladder is also possible, but again, it would have to be in a patient who already has a bladder that's not so strong to begin with. Those things don't get ruptured that easily. This question definitely caught a lot of people off guard. I'm pretty confident about that. This question was a good way to test how ready you are with genetics understanding. They did a good job picking a disease that doesn't really necessarily have an inheritance per se. So this is about beta thalassemia. A 26-year-old man and his 25-year-old wife come to the physician for genetic counseling prior to conception. Both of the patients were previously found to have microcytic anemia and an increased fraction of hemoglobin A2. which is all telling you that this patient has a lack of beta globin, which is why they have more alpha globin stuff, hemoglobin A2. Genetic analysis shows that the man has a heterozygous null mutation of the beta globin gene, and the woman has a heterozygous mutation known to cause a 50% decrease in beta globin gene function of one allele. Which of the following best represents the beta globin function possibilities for this couple's offspring? You read all of that and then you get lost, and that's because you might not be confident with the tools that you have to tackle genetics questions, right? Your understanding of Punnett squares, your understanding of all the different ways of inheritance, how genes move from one person to another, and everything else that's responsible there. So this question was easiest to be answered through a Punnett square, and you could think of that by the way the answer choices are given, right? 1 in 4, 1 in 4, 1 in 2, 1 in 2, which is basically 2 and 4. So the 4 should make you think of, okay, 4 things that I can pick from, like in a Punnett square. So you make a Punnett square, you put all the, both of the parents into it. So the man has B and B0, B0 being the null mutation he has. The woman is B and B plus, the B plus being the 50% decrease that she has. You do the Punnett and you fill it out, and then you can see what's happening, right? So this one right here is the one with 100% beta globin production, function, all of that. This one with the missing the null mutation would have 50% beta globin production, because only one of the genes, which is this one, this is the normal beta globin function gene, only that gene would be working, so 50%. This one here, the BBB plus, this one is just like the mother, right? So 75% globin gene production. 75, how do you get 75? So each beta gene is making 50%. So remember that she has a 50% decrease in beta globin gene function of one allele, which is basically a 25% decrease of the whole thing. So if you're confused about that, that's basically like, let's say you have two alleles, allele 1, allele 2, right? This one is going to have 100% function, so you just put 100%. This one is going to have 50% function, which is what they told you, so that's 50%, right? And these two numbers don't add together like that, right? So if you were to add them together, then you would rewrite it in a different way. So then maybe, how do you add them together? Well, together they would have 50-50, right? That would be the normal. Add them up, you get 100%. But this guy's working perfectly fine, so that 50 is going to remain. This guy, they said, has a 50% decrease, so that would be 25, and that gives you 75. Right? So that's 75%. This is how the mother is, and there's a chance one baby is going to be just like the mother. One baby is going to possibly be worse than both parents, right? And that's the null mutation plus the mutation of the other one that has a 50% decrease. So that makes it a 25% beta globin production. Then you have all your data of all the possibilities that this patient can, this family can have kids in. All the possibilities are there now. So knowing all those possibilities, you go through your answer choices and you would come down to picking B. B would be the only plausible answer choice you would go with, which basically says 1 in 4 will have less than, sorry, did I pick the right thing? What did I, 1 in 4 will have less than 10% beta globin. 10%, what did I do? Give me a second, guys. I keep messing up the letters I put here. This is 1 in 4. 25% decrease, not the 10. This should be C, excuse me. Man, this is not fun to do while you're fasting and stuff. Let me just delete this real quick. So once you're done with the chart, you can see that answer choice C will be the correct choice, which is 1 in 4 will have 25% beta globin function and may require occasional transfusions. You can definitely try to guess, but for guessing purposes, you would have to knock out some answer choices at least, because right now there's 5 choices. And that means that if you were to guess, you would have a 20% chance of guessing correctly, and that's not a safe one to go with. So, this one all will have decreased beta globin function and transfusion-dependent anemia. You can definitely cancel this out, right? Because this would only be true if both parents had homozygous mutations, and they don't. So A is impossible. 1 and 2 will have normal beta globin function without need for transfusions. This you might be able to cancel, but if the only way to cancel this out would be a mental Punnett square, right? If both parents were BBO, then it would be possible because 2 of them would get BBs and BBs, and that would be a perfectly normal one. So if you thought of a Punnett square, you're already done with the question anyway. If you didn't think of a Punnett square, you can only cancel out answer choice A for the most part. Maybe cancel out B if you're thinking that sounds a little too extreme, and then pick something. But guessing isn't exactly the best way to go. So here the answer would be C. 1 in 4 will have 25% beta globin function and may require occasional transfusions, which is this one right here. Right? So this would be the reason they would want to consider whether or not they want to have kids. And usually this kind of counseling you get done before getting married, because this is very critical for communities and ethnicities that have a lot of thalassemias in them. This is especially critical for sickle cell patients. I've worked in a hematology rotation where patients would come in to find out if their boyfriend or girlfriend has sickle cell as well, and they would have to get the testing done and everything to make sure they don't, because it's highly advised against to let two patients who are both sickle patients have kids. You're basically punishing your child by selfishly getting with each other and marrying each other because your child is going to have sickle cell. So that's really dumb. You don't want to do that. If you have sickle cell, you want to marry someone who does not have sickle cell to minimize the chances of having a baby with sickle cell disease. Being a sickle cell carrier is understandable and survivable, but having disease, sickle cell, that's not going to be good. You don't want to purposefully put children into that. So that's what happens in this question. Always remember to apply Punnett squares to everything you can. I don't get a chance to revise these. I just keep finishing explanations, and then I guess I kind of revise them as I'm streaming it with you. So don't mind the errors, but we will catch any errors if there are any as I revise it with you. This question 34, a 6-year-old girl is brought to the office by her mother because of a 2-day history of a severely itchy scalp. So if a 6-year-old girl comes up to you and she's scratching her hair, you immediately think of lice. The mother reports that 10 children in her daughter's class also have the same symptoms, which is because lice spreads really easily from kids playing with each other. The patient has no history of major medical illness, doesn't take any medications, vitals are fine. Examination of multiple hair shafts show 1 to 2 millimeter white globular protuberances. What's the most likely cause of the condition? And that would just be C, pediculus humanus capitis. Don't fall for Sarcoptes scabiei, which is the guy that causes scabies, right? Those are the only two different guys you want to worry about. So that would be 166. Let's take a look at it real quick. Very low yield topic. I mean, I would be surprised if your step 1 has a question on the pediculus stuff because it's just too easy. But I've definitely seen UWorld ask a lot of questions about the scabies stuff, right? And NBME has also in the past. So this is what they were all talking about. These are the two guys. Our guy is pediculus humanus. Blood-sucking lice that causes intense pruritus with the associated excoriations, commonly on the scalp and neck, right? So that's the head lice. Waistband and axilla and pubic and perineal area, all different kinds of lice with different names. There's also other stuff here. So body lice can transmit rickettsia, Borrelia recurrentis, and Bartonella quintana. Treatment includes pyrethroids, malathion, or ivermectin. And I've seen questions about these guys as well. Their mechanism of action, how they work. Definitely a high-yield topic in that aspect. Children with head lice can be treated at home without interrupting school attendance. And although this is true from my experience, what I've seen is school attendance usually gets interrupted. So I know family members who had their daughter had to stay home for 3 to 4 days until it went away. So school attendance can be interrupted. They say it can be treated without it, but I've always seen it being interrupted in my experience. But as far as the test is concerned, I guess you would pick that school attendance is not interrupted. 50-year-old man undergoes surgical resection of the obturator nerve for unbalanced muscle spasm affecting the hip. Which of the following muscles is the most likely to be paralyzed by this procedure? Right, so they're basically saying they're going to paralyze your obturator nerve. And if you've done enough musculoskeletal studying, I always remember obturator nerve as the guy that helps adduct. It is a medial nerve. Right, so this is a guy standing looking at you. Right, this is the front of their leg. Right, you're looking at the dorsal aspect. So there's the penis and all that. So dorsally, this is the medial side. So this is obturator nerve sensory area. Right, obturator nerve works with all your adductor muscles. And they were nice enough to put answer choice A as an adductor muscle, and almost make it seem too easy, but that was actually it. It's just adductor brevis. Obturator is an adductor nerve. It innervates adductor longus brevis and magnus, obturator externus, the gracilis, and pectineus. Now there are a couple things you need to know. The obliques, external oblique being as choice B, are not exactly hip muscles or even part of the legs. They're muscles of your torso. The internal oblique is innervated by iliohypogastric nerve. Obturator internus, which is another answer choice you see as choice D. I'm surprised they didn't put as choice D as choice A, so that you would see it and immediately pick it. But obturator internus is actually not innervated by the obturator nerve. Remember that these names are not exactly related to the nerve supplying them, but they're rather related to the activity of the muscle. So it is a muscle that causes adduction to occur, so it's named correctly in that manner. But obturator internus is a trick answer because it actually has its own nerve. So in the sacral plexus, there are many nerves that are directly going to the muscle. Right, so you can see right here, this is the nerve to the obturator internus and the superior gemellus. There's also other nerves that go straight to specific muscles, like the piriformis, which is also another answer choice. Right, nerve to the piriformis, nerve to the quadratus femoris and inferior gemellus. All of those guys have their own direct nerves, not nerves like these guys, the femoral obturator, etc., etc. So worth revising at least once, so it rings a bell when you see it. You can immediately cancel out piriformis. You can cancel out obturator internus. Iliopsoas. Did I put it here? Iliopsoas is a dual muscle, so it has the iliacus portion. It also has a psoas portion. The iliacus portion is innervated by the femoral nerve. If you could just remember that, then you're good to go, and you understand that has nothing to do with this. Okay. So all in all, this could have been a harder, more unknowing question, but it was pretty easy. Just because they put the adductor first. If you remember adduction is the operator's job, you're pretty set. This was an okay question as well. 24-year-old man is brought to the office because of fever and chills for one day. Paraplegic, uses a wheelchair, has recurrent urinary tract infections, treated with different antibiotics over the past year. Temperature is high, so he's definitely infected today too. Urine cultures are ordered and treatment with ciprofloxacin has begun. 2 days later, he is still febrile, and the initial urine cultures grow E. coli that is resistant to ciprofloxacin. What is the most likely cause of this organism's resistance? They really tried to get you with answer choices A and B, but neither of those are true. That would be through conjugation. Conjugation would require another bacteria, and urine culture only grew E. coli. Could it be that there were two E. coli's where one E. coli has the plasmid for ciprofloxacin resistance? Not really. Very unlikely. Very, very, very unlikely. And the question doesn't give you enough to really think of that. On top of that, even if it was possible, the plasmid encoding ciprofloxacin acetylase and then the plasmid encoding 23S ribosomal RNA methylase, only answer choice A is a real thing. So if you look up ciprofloxacin acetylase, you'll actually see that that's a real mechanism of E. coli resistance to all the floxacins, but fluoroquinolone resistance in that manner doesn't necessarily occur from acquisition of the plasmid. Not enough information is given for you to pick A or B. This was a straightforward question about why this medication, ciprofloxacin, is not working in this bacteria all of a sudden. And it would have to be with the target of ciprofloxacin, fluoroquinolones. Remember that ciprofloxacin is fluoroquinolone, which works on topoisomerase 2 and 4. Topoisomerase 2 is called DNA gyrase, right? So that's answer choice C. Alteration in the DNA gyrase is one of the mechanisms of resistance to fluoroquinolones. So this is a pretty common thing they like doing in NBME. There are other questions from the same kind of topic of stuff in the same NBME so far, where they pick on microbiology treatment, microbiology pharm, and ask you about the resistance or mechanism of action. This question was plasmodium related, which should be the first thing you think of when you see something like this. Any image like this should make you think of either plasmodium or gonorrhea, for the most part. But as soon as you start reading the question, it should make more sense for one over the other. 30-year-old man who is a migrant farm worker, comes to the emergency department because of a 1-week history of fever, chills, and severe headache. He immigrated to the Midwestern USA from Honduras 1 year ago. He is alert, temperature is high, pulse is 101 per minute, respiration is at 20 per minute, and blood pressure is 105/62. Lungs are clear. Cardiac exam shows no abnormalities. Abdomen is soft with active bowel sounds. Neurologic exam shows a supple neck, no nuchal rigidity. So all of those things are perfectly fine, but they made the effort of listing it all out for you, which is annoying. You look at lab studies, everything's looking pretty fine, nothing insanely bad here. And then they go on and tell you, a photomicrograph of peripheral blood smear is shown. Patient's overall condition is most likely caused by an infectious agent with which of the following features, right? And you look at your answer choices, and it should ring a bell for Plasmodium, malaria. And then you come back to the question, he has fever, but everything else is fine, so that sounds a lot like malaria. And malaria does look like that, so this would be formation of hypnocytes. Now, why would you pick formation of hypnocytes and not the chloroquine resistance? Well, keep in mind that he's been in America for a year now, right? And you don't necessarily get malaria in America. It's a very remotely rare thing, almost impossible. But he must have brought dormant hypnocytes with him from the Honduras. And then at this point, he might have gotten sick, become immunocompromised or something, and now it's reactivating, and that's what we're seeing here. Right, so this is definitely Plasmodium. This link right here actually is a nice link that is the exact source of this image. Actually, this is where they got the picture from. And in that link, they actually have more information regarding this stuff and a couple more images of the same patient and the infection progressing. So you would check that out if you want. But yes, this was just formation of hypnocytes, nothing insane. This was also a good question. So a 37-year-old woman comes to the physician because of nausea and vomiting. She drank too much, right? Half a bottle of whiskey previous evening because I was in great despair because my boyfriend broke up with me. I normally don't drink alcohol, but I had to calm my nerves. She describes her mood as depressed, angry, and unstable. She says, there is no one I can trust except you. I recently started a job, and from what I can tell, everyone I work with is a jerk. This patient most likely has which of the following personality traits. And NBME tried its best to kind of make it more vague, but they gave away exactly what's wrong with this patient. First, we have the fact that she's doing all this impulsive stuff, right? Drinking all this. She claims that she has an unstable mood, and then she does this act of splitting where saying everyone she works with sucks, and you are an excellent person, you she can trust, but everyone else she works with sucks. So that's splitting right there, and these are all signs of borderline personality, right? I went on to tell you about the other personalities. So she best fits borderline due to her unstable mood, impulsive reckless drinking, emotional emptiness, and work-related splitting. Antisocial is in the same cluster, cluster B, but that would be criminality, right? Narcissistic is also cluster B, but that would be grandiosity, and she doesn't exhibit that at all, right? So in my book, in my lectures, when I talk about the clusters, well, I associated them with images, right? So cluster A was your accusatory, schizoid, or schizotypal. And it's this guy. It's very robotic, right? So very robotic and very schizotypal because it is eccentric. Imagine walking around dressed like that. Cluster B is Cardi B, so that reminds you of all the things you can associate with how she carries herself. Be creative. And cluster C is Sheldon Cooper, the intelligent guy, who is very dependent, right? Very dependent from the show Big Bang Theory. So that's what I used because it helped me kind of memorize what each cluster was about and what different personality traits go within each cluster. This question was really hard. It was weird. I don't know where it's coming from, but NBME always has at least 2 to 3 questions like this, sometimes 5. 55-year-old man with type 1 diabetes comes to the physician because of intermittent burning pain of his feet during the past 4 months. Right? So he's diabetic and he has burning feet. That's diabetic neuropathy. Examination of the feet shows allodynia bilaterally. Sensation to pinprick is decreased. Motor strength, deep tender reflexes, joint position, and vibration are normal. Which of the following is most likely cause of the pain in this patient? So after looking up what could be the explanation, the main thing to focus on here was the allodynia. When I was doing this question, I wasn't sure what to go with. I was thinking between Dorsal root afferents, answer choice D, or actually I was just stuck between D or E. Yeah, I knew it wasn't going to be A, B, or C. So A, B, or C, they tell you have increased activity of glutamate in the dorsal root ganglia, GABA in the dorsal horn, or voltage-gated potassium channels in the thalamus. I didn't feel like any of those were really significant. But yeah, inhibition of vanilloid receptors in the dorsal root afferents just sounded like an NBME type of answer choice that would be legit. And then E, persistent activation of voltage-gated sodium channels in the nociceptor felt pretty legitimate too. Allodynia is feeling pain to something that isn't normally painful, right? So maybe someone pinches you, you feel extensive pain, even though to anyone else that wouldn't be extensively painful. And that's what choice E is, right? So allodynia, excuse me. This is one of the worst parts about fasting. You end up having like a really bad sleep cycle, and you are always sleepy. Allodynia is not due to central things like the dorsal root ganglia or GABA or receptors in the thalamus or even dorsal root afferents for that aspect. Choice E depicts a peripheral receptor being overactivated, as is the case in peripheral sensitization, and that's what this patient is going through. This patient has peripheral sensitization due to the diabetes. Especially if you're new to studying for step 1, that's like a great time to start off, because my annotated PDF, I have a video of it. I can send you that too. It summarizes everything in such a way that if you're like following along with my full first aid mastery playlist, you get a really solid understanding of what's happening and how you memorize it, how you're supposed to master it and retain it for test questions. So great time to get it right when you're starting. It's everything that you need. Okay, so this was just E, right? This is a weird question, not exactly in first aid either, so if you know something, you can answer it. If there's something you don't know, then you can try your best to guess. I wasn't able to. I picked D. Number 40, okay. So they gave you this image, and they tell you a 75-year-old man is brought unconscious to the emergency department by his wife after he collapsed 30 minutes ago. The wife says he had abdominal pain that morning, but he did not intend to visit the physician. He has not had a physical examination since childhood. His wife says she has been begging him to go to the physician ever since he noticed an abdominal mass 2 years ago. So he just ignored everything. He has smoked 2 packs of cigarettes daily for 60 years and drinks 3 12-ounce cans of beer daily. Temperature is pretty normal. Pulse is 80. He has premature ventricular contractions, so that's pretty bad. And then respirations are 35 per minute. Blood pressure is okay. Physical exam shows a pulsatile abdominal mass and minimal bowel sounds. CT scan of the abdomen is shown, which of the following is the most likely underlying cause of this patient's condition. So when I did my family medicine rotation, something that my proctor would keep mentioning was that anytime you get an elderly white man who has a history of smoking, you check for a pulsatile abdominal mass. That was something that she would teach us and drill into us. And, we don't know if this guy is white, but he is an elderly man with an extensive smoking history, and they tell you he has a pulsatile abdominal mass. The reason you check for all of this is to check for a AAA, abdominal aortic aneurysm. Okay? And an abdominal aortic aneurysm is the long-term effect of atherosclerosis, which is an inflammatory procedure. Right? Atherosclerosis causes inflammation, leading to aneurysmal dilatation of the abdominal aorta. In the image, calcification of that same aortic wall has occurred after the inflammation and dilation. These links over here are just really good links for running through a case scenario and understanding this kind of presentation. They have more images in it. They also tell you how you're supposed to approach such patients to really confirm if this is what's happening. Okay, so good stuff right there. Let me put that in the chat too, so that anyone watching can just click on it. All right. So here was another anatomy question. 41. A 32-year-old man is brought to the emergency department after sustaining a deep laceration that may have injured the nerve supply to the flexor digitorum profundus muscle of the index finger. Which of the following movements can be used to specifically test for the function of this muscle? So basically they want to know, what does this muscle do? The flexor digitorum profundus. Now, the Teach Me Anatomy images are actually my favorite ones to use, and I have them incorporated into my annotated PDF too. They're probably the most helpful ones for really getting a good understanding of where muscles originate and where they insert, ultimately. The profundus is profoundly long. That's a good way to memorize it, right? Profundus is profoundly long. It's an extremely long muscle. It goes all the way. So this blue muscle here is the flexor digitorum. It goes all the way to the distal joints, right? And it's a flexor, so its job is to help you flex your fingers. Okay, flexor digitorum profundus. Very important to remember these guys. Okay, so the image we're looking at with the blue is showing you this, like this. This is the left hand and the palmar surface, and the flexor digitorum profundus would be responsible for the four fingers besides the thumb, not the thumb. The thumb has its own guy, right? So that's the flexor pollicis longus. Memorizing that isn't exactly the hardest stuff. When you revise these things, it should ring a bell and it should stick to you. Abduction and adduction of fingers is not relevant. You should have been between C, D, or E. And then metacarpophalangeal joints, that's done by the lumbricals. So, that's not relevant here either. Between C and E, to be confused is pretty normal. And then you would pick C if you remember that, profundus is profound. It's profoundly long. It goes all the way to the end of your fingers. Choice E would have been flexor digitorum superficialis. That's the one that would be more superficial, more proximal. Okay, so different ways of memorizing it. Use what helps you master it. On this side, I'm showing the flexor digitorum superficialis tendon in green, so you can see how it's more proximal, right, attaching to the proximal interphalangeal joint. The yellow one here is the same flexor digitorum profundus going all the way to the end. Okay, and on the top you have your extensor digitorum. Right, so the extenders are for extending. 42. A 32-year-old woman who is 20 weeks pregnant has had increasingly severe episodes of heartburn for the past 3 weeks. She has mild epigastric tenderness on palpation of the abdomen. Which of the following drugs is contraindicated because of an increased risk for spontaneous abortion? So basically, which of these drugs cause abortion? And that's just misoprostol. Very straightforward question. I wish every question was this easy and straightforward, but we can only wish. This one was slightly confusing, but nice question. A lot to talk about here. 55-year-old man is brought to the emergency department because of a 1-hour history of severe chest pain, nausea, and vomiting. He's agitated, clammy, and sweating profusely. Temperature is 98 F, pulse is 130 per minute, respiration is at 36 per minute. Blood pressure is 85/45. Okay, so what we're seeing here is the clammy aspect, the sweating aspect, and a very low blood pressure. It looks like shock. Okay, jugular venous pressure is 12, and crackles are heard in the lung bases bilaterally. Which of the following hemodynamic changes is most likely in this patient? Now, you hear crackles in the lungs, but his fever is not, he doesn't have a fever. His temperature is normal, so those crackles are due to edema, pulmonary edema. Now it could be cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. For our patient, once you start thinking in this manner, for our patient, it seems like our patient might be going through cardiogenic shock, leading to cardiogenic pulmonary edema, which is what's causing the crackles that you're hearing. Okay, that much you should be able to establish from reading the question if you studied enough and you're ready for step 1. If you're not yet ready for step 1, then this is the level of understanding that you're trying to get to from reading a question. You look at your answer choices asking about PCWP, cardiac output, and systemic vascular resistance. And this is directly from the table that talks about shock in first aid. And in my annotated first aid, I have extra information to break down each one. Hypovolemic, obstructive, distributive, neurogenic, all the different kinds of shocks you can have on your test. Now, septic shock is a different thing, and that's part of distributive. And that would have a fever. And a septic shock or distributive shock in general from any reason is the only time where cardiac output is high and systemic vascular resistance is low. Right? You should always remember that. This is a person with infection. They're going to need vasodilation to send antibodies somewhere. That's something I always think of. A distributive shock is distributing blood everywhere, so you're going to have excessive vasodilation to send stuff everywhere. And that's kind of how I thought about it, so I could always remember distributive shock has a very low blood pressure. All in all, though, no matter the type of shock, the underlying physiology is the same because cardiac output times systemic vascular resistance gives you your mean arterial pressure. For our patient, blood pressure is already pretty low, right? So the body's going to try to fix that by increasing systemic vascular resistance and decreasing cardiac output. That's what you should come to as soon as you know it's not septic shock. It's a shock that isn't distributive. Right? So once you figure that out, you can cancel out any acid choice where it's not like that. So you want to have an increased SVR, right? So you can cancel out choice C and choice E. And then, of course, with increased SVR, you want to decrease cardiac output, so you would keep B and D. So you're really just between B or D. Right now you're at a 50-50 choice. If you're running out of time, just pick either one, B or D, lock it in, finish it up, right? You're done with your test, go home. If you have time, then you think about it now, because now comes the harder part. PCWP, unfortunately, first they didn't do a good job to tell you exactly what it would be. They didn't spend time breaking down each one of these case scenarios in this page, but those case scenarios are broken up in different parts of the book, right? And that's what you're supposed to do when you're studying. You go to different parts of the book, you look up different videos like this one from Osmosis, all the different resources you have, and master the information. Don't just take it for granted the way it's written here. So for PCWP, you can see it could be high or low, which means that you're stuck because the only difference between answer choice B and D is the PCWP. So do we want our PCWP to be high or low? This information will come from your knowledge of PCWP. What does it do? The pulmonary capillary wedge pressure actually checks for pulmonary capillary pressure in the left atrium, right? And if you have any reason for pressure in the left atrium to be very high, then PCWP will be high. Otherwise, it'll be low. Okay, and the iconic reasoning you think of is mitral stenosis. With mitral stenosis, the mitral valve not wanting to open, there's a lot of pressure in the left atrium. PCWP will be very high, more than 12. The only information they gave you was that the jugular venous pressure is pretty high. It's supposed to be between 6 to 8. Okay, jugular venous pressure is pretty high, and then there's also issues in the lung. So what does this tell you? This is a cardiovascular understanding. If your JVP is high, that means something's wrong with your right heart. It's not functioning correctly. Blood is backing up into your jugular vein, right? Your jugular vein up to your right atrium, there are no valves. So blood free flow comes into your right atrium. The only valve there now is going to be the tricuspid valve, and then of course the pulmonic valve. So if blood is backing up in the right heart, it goes up into the jugular vein, and that's what you're seeing there. Crackles in the lungs are an issue of the left heart. If blood cannot come back from the lungs into the left atrium, then blood backs up into the lungs and you get cardiogenic pulmonary edema. So it seems like this patient has some kind of heart failure or MI that's affecting both sides of the heart, right? And since he has crackles and blood is backing up and whatnot, there would be an elevated PCWP, and that would be answer choice B. Okay? Not so bad at all. Just a great question to see how well you understand how all of this stuff works. This question was again cardiology related, about the pharmacology aspect of things. So a 62-year-old man comes to the physician for a follow-up exam. 1 month ago, he was diagnosed with atrial and ventricular arrhythmia, and appropriate pharmacotherapy was initiated at that time. All right. Today, his pulse is 64 per minute. Blood pressure is 136/88. 1 month ago, his pulse was 78 per minute, and blood pressure was higher. So now his pulse and blood pressure are both lower. His pulse is almost too low now. You don't want pulse to be around 60, and definitely not ever lower than 60. So 64 isn't that bad, but still, it's pretty considerately, I would consider that bad because the patient's 62. So there's a specific medication we're all thinking of at this point that he might have been given that's causing the pulse and blood pressure to go down. Physical exam shows no other abnormalities. ECG shows normal sinus rhythm with a prolonged QT interval. Which of the following drugs was he given? So you want to first figure out which of these drugs can cause prolonged QT interval, and then understanding what would cause a decreased pulse and blood pressure. So pulse decreases or heart rate decreases when you block beta-1 receptors, right? Beta-1 receptors. Never really want to give beta blockers to elderly patients because it can cause so many different issues. One being a decrease in heart rate, which can be fatal. Prolonged QT interval from all these answer choices really only occurs with sotalol. So you have to memorize all the drugs that cause prolonged QT interval. How you do that is up to you. but the general theme is obviously revision and studying. From your class 1 drugs, right? From your class 1 drugs, the one that's notorious for causing QT prolongation is just class 1A. When I taught these medications, I taught you that, first one in class 1A, someone's pushing from the left, right? Then someone pushed back from the right, fixing it, right? And then again, someone pushed harder from the left, but didn't alter it. So you can see QT is normal in 1B and 1C, but in 1A, the QT prolongation is occurring, right? This is longer now. Effective refractory period is longer here. That's all pretty much the same stuff. So QT interval increases with these medications, but none of them were an answer choice. QT also increases with class 3, right? But not with all of them. So this was actually a question that UWorld had, and it was really annoying that they had that question, but it did the job. It taught you something. As annoying as it might be, we're always annoyed by things that are intimidating, but it did the job. And that question was basically asking something about class 3 medications, and it wanted you to pick one that you could give to a patient who has problems with torsades, okay? The lesson of that question was that, antiarrhythmics here do cause QT interval prolongation, but not amiodarone. So as bad as amiodarone might be with its lung, thyroid, and liver problems, it doesn't cause QT prolongation. And you always want to make sure you remember that. The other guys do. So sotalol, abutolide, and dofetilide do cause torsades. They do cause QT prolongation. So if you can remember, the amiodarone is unique for so many different reasons, including it not causing torsades, then you'll remember the others do cause torsades. And that was the only answer you could pick. Okay. I also listed out what the others are for, and those other ones, flecainide, phenytoin, metoprolol, aren't of class 1A or class 3. This was a pretty straightforward question. If you're new to step 1 prep, you might get it wrong, but other than that, it was pretty clear what's happening. So a 34-year-old woman with a long history of rheumatoid arthritis, refractory to treatment with corticosteroids and methotrexate, comes to the physician because of a 2-week history of increasingly severe low back pain, decreased appetite, and malaise. She has never had low back pain in the past. She has not had fever, lower extremity weakness, constipation, bladder or bowel incontinence, weight loss, or sensory changes. None of that. So what's new? A patient comes in like this, you ask them, so what's new? Has something changed recently? She'll tell you 6 weeks ago she began treatment with infliximab because of bilateral wrist, hand, and knee pain from the rheumatoid arthritis. And that should give you the diagnosis right there. Her temperature is perfectly fine. Physical exam shows mild tenderness over the L1 to 2 vertebrae. You look at all her lab studies, her hemoglobin is a little low, but other than that, things are okay. MRI of the spine shows osteomyelitis of L1 to 2 with destruction of the intervertebral disc space and 1.2 centimeter adjacent abscess. The abscess is debrided, and samples of the abscess and bone tissue are sent for analysis. A Gram stain is negative, which is obvious, should be expected, if you know what's happening. Pathologic exam of the bone specimen shows acute and chronic inflammation with granuloma formation, which is a giveaway. What is most likely happening? She has tuberculous osteomyelitis. Infliximab is one of the TNF-alpha inhibitors, and you can remember all of them with whatever you want to. For me, I made up a phrase in Hindi. It goes, in ada se goli marti, totally not fair, and I've written it right here. Right, so in ada se goli basically means you're shooting. Goli is a shot, like a bullet, and ada is kind of like beauty. So in ada means with these beauty, or with your beauty, you're shooting me. It's a very corny little thing that can be said in like songs or stuff and in Bollywood, but it does the job here because all your TNF-alpha inhibitors are pronounced in that way. So there's adalimumab, certolizumab, golimumab, something like that. Those are all the different TNF-alpha inhibitors, and our patient took infliximab. These TNF-alpha inhibitors, you can remember because they're totally not fair for TNF. Once you take a TNF-alpha inhibitor, you can no longer have a macrophage granuloma. And once the granuloma goes away, you no longer contain the latent TB. Right? So the latent tuberculosis becomes rampant again. And you can get disseminated tuberculosis, which could lead to Pott's disease. And that would be the involvement of her lower back, right? TB or mycoplasma is acid fast, so it doesn't really stain with gram stain. That's all this question was about. 46 was slightly confusing. Okay, I guess someone can be totally confused about these things even if you have studied it. 32-year-old woman comes to the physician because of a 7-day history of sneezing, nasal stuffiness, and watery eyes. She has a history of similar symptoms each spring while gardening. Temperature is fine. Which of the following types of cells are most likely to be increased in her nasal secretions as a result of this reaction? Right, so wording of NBME questions is always pretty critical. The way they say something means a lot. So you could tell, obviously, that she has seasonal allergies, right? Each spring while gardening. So she has seasonal allergies. So you know this is about allergies, so you can cancel out choices A, C, and E. Basophilia is more so relevant for cancer, leukemias and stuff, lymphomas. Lymphocytes are just white blood cells, irrelevant to this kind of stuff. And same for monocytes. This is definitely going to be about mast cells or eosinophils. Kind of messed up that they put mast cells here, but it was because of the way they worded the question. So read the question carefully. They want the result of this reaction. The reaction is going to be mast cell degranulation. That's how you get allergic reaction. The result is going to be from later activity by eosinophils, which are activated by interleukin 5, and there's going to be IgE clustering and cross-linking. It's all a type 1 hypersensitivity reaction. Okay, so nasal secretions will have more eosinophils. Nasal secretions will not have more mast cells. Mast cells are degranulating throughout wherever in her body before inside her nasal secretion. The nasal secretion itself is going to have more eosinophils, and that's choice B. This question is a great question that takes to home a very important lesson from renal. 35-year-old man comes to the physician 1 week after he had high blood pressure reading taken while he was donating blood. Pulse is 76, blood pressure is super high, 180/100. Physical exam shows no abnormalities. Treatment with losartan is started, and that's an angiotensin receptor blocking agent. Which of the following is most likely to occur in this patient? So, let's go back to our renin-angiotensin. Okay, so when you come here, right, you can see everything here. So there's two things that we commonly give. You could give ACE inhibitor to a patient, right, like Lisinopril. If you give ACE inhibitors to a patient, you no longer have bradykinin breakdown, and the accumulation of bradykinin can lead to dry coughs in these patients, which is super annoying, especially in the time of coronavirus. You don't want anybody coughing, so you don't give them the ACE inhibitor. If they have cough, or if you feel like losartan would just be better for some reason. Losartan is an angiotensin II receptor blocker. So what it does is it effectively blocks off any of this activity. So you're not going to have more ADH, you're not going to have more aldosterone secretion. That would suck because aldosterone causes hypertension. So if you give an angiotensin blocker for hypertension and then increase aldosterone to make more hypertension, you're not treating anything. It would not cause more sodium hydrogen activity at the PCT. It would stop the ACE effect. Remember, ACE, angiotensin constricts the efferent. And if you're taking lisinopril or losartan, you would stop the constriction of the efferent arteriole. Right? ACE, angiotensin constricts the efferent. You would stop the efferent constriction, so things would pass by more quickly, and you would increase filtration factor. Right? But preserves GFR if the renal blood flow is low. And this is something that often gets tested. It's a whole different topic. We already talked about it in the question yesterday from the first half of block 2. But this is often something that gets tested. It was a question about a guy whose renal artery was not bringing in much blood, and they wanted to know how you could fix that while maintaining GFR and maintaining renal plasma flow. All right, so very important to remember that. Constricting the efferent helps. And then, of course, you're going to decrease the direct effect of angiotensin II, which is more vasoconstriction. So through various mechanisms, you will help against blood pressure. However, angiotensin II will still be made. Right? Your receptor is just not reading or taking angiotensin II onto it. So there will be a feedback upregulation where you're going to try to make more angiotensin II in efforts of ramping up angiotensin II activity. And that was choice D. This was an okay question, just weird wording. Immediately after a spontaneous vaginal delivery, a full-term male newborn is found to have a tuft of hair on the midline in the lumbar region. Palpation of the area shows an absence of spinous processes in that region. Imaging studies show no additional abnormalities. The most likely cause of this defect was failure of which of the following events during gestation? So tuft of hair, midline, palpation showing absence of spinous processes. All of that is a giveaway for the occulta, spina bifida occulta, neurotube defect that usually has a tuft of hair and is just missing some bit of spinous process. That is a result of fusion of sclerotomes failing. Answer choice D. The other answer choices are completely off. You should not have any reason to pick them, right? If you have a problem with development or formation of the neurotube or notochord, any of that, you're going to be missing the whole spinous process. The whole central nervous system, not the spinous process. You'll be missing the whole central nervous system. And that would really suck, So that would be a bigger deal than just the tuft of hair and the occulta. Formation of the yolk sac is irrelevant, and migration of neural crest cells don't have anything to do with the spina bifidas. Those are irrelevant entirely. Those spina bifidas are 537. Are unique from multiple other things, like there's AFP, right? AFP is going to be high, except in the spina bifida occulta. Remember, occulta means it's hidden. Okay, so I always think of, like occult blood test, for example, fecal occult blood test. You're looking for blood that's hidden in the feces. So occulta means hidden, and it's going to be hidden in the tuft of hair. So you can always remember that. AFP is going to be normal in these people. It's not going to be there. This missing spinous process, this area right here, is a problem from fusion of sclerotomes. Right? Sclerotomes are not fusing. And I wrote over here what each one is about because there's different kinds of tomes. Right? So sclerotomes are for the vertebrae, myotomes are obviously for muscle, syndytomes I've never heard of are for cartilage and tendons, and then dermatomes we all hear about related to the skin. Dermatome, so for skin. Another interesting question. So, 35-year-old woman comes to the physician because of a 1-year history of fatigue and lethargy. She had a 20-pound weight gain during this period. She says that she has to wear a coat in her office because she's always cold. So all of this is sounding like hypothyroidism. Physical exam shows coarse skin. Examination of the neck shows no palpable thyroid gland tissue. Neurologic exam shows a delayed relaxation of the Achilles reflex. All signs of hypothyroidism. Serum concentrations of T4 and T3 are low. Thyroid scan shows localization of the radioiodine in the midline of the inferior aspect of the oral cavity. No radioactivity is detected in the neck. The radioiodine is most likely localized inferior to what structure? So there's another question about the same exact region, this endocrine embryology, coming up in like another 10 questions, which we'll do tomorrow. But you look at all your answer choices, this must be coming from foramen cecum. It's the only thing directly related to having thyroid tissue somewhere else. Okay, so that's all this was really about. You're not going to pick frenulum of the tongue. That doesn't make sense. Okay, the tongue is involved, but not the frenulum. So that's really all that's going to be. Nothing insane there. This one was okay also. They did a good job in giving you everything you would need. Results of a 5-year screening program for HIV infection in a population of 10,000 commercial sex workers are shown. So you see time intake, 1 year, 2 year, 3 year, 4 year, 5 year. Number of people remaining in the population. So others might have died, I suppose, or moved, right, traveled. You can drop out of any clinical trial or screening program whenever you want. Number of new patients with positive serology. Which of the following percentages is closest to the average annual incidence of infection in this population? They gave you everything you needed for this question, right? This question tells you the number of people in the population and the number of new cases, the two things you need for calculating incidence. They didn't even try to confuse you with incidence versus prevalence, where people often tend to forget to remove those people who already had disease, right? You always look at people that are vulnerable to the disease versus people that just got the disease, okay? And I calculated it for each one, and you can see those percentages right there, and it was pretty much as close as to 5%. So that was it for that. All right, nothing insane. This is let me see what page, incidence, right? So that should be, I forgot to write the page number there, but incidence. So right here. So page 259 of first aid 2019. Incidence. Number of new cases versus number of people who are at risk. So you never count people who have the disease already. Okay, not bad. Thank you very much for joining, guys. In the next video, we'll go into block 3 and do the first 25 questions over there.